So, on behalf of BLK Center for Child Health and IAP Central Delhi branch, I, Dr. Swati, welcome you all to this BLK Techniques webinar. As we know, X-ray is a very basic and versatile investigation which is available everywhere. It can be performed even in the sickest of newborn. And last two sessions we had done on abdominal X-rays in surgical conditions and also neuroimaging in pediatrics. So continuing the same series on imaging, this time we have a session on neonatal X-rays. The speaker is Dr. Kumar Ankur. He is the director and head department of neonatology at BLK Center for Child Health. And to chair the session, we have with us Dr. Kanika Sethi. Ma'am is head of the department of radiology at BLK at Max Dwarka Hospital. Welcome, ma'am. And Dr. Sushant, he is senior consultant pediatrics and neonatology at Apollo Cradle Hospital. So over to you, Dr. Ankur, the session.
Thank you, Dr. Swati, for the introductions. And thank you, Chairpersons, Dr. Kanika, Dr. Sushant. Am I audible, ma'am?
Yes, your voice is very clear.
So let me share first. Is it visible?
Yes, your slides are visible. You can start.
Kanika, ma'am, shall I start or will you say something? Or okay. So thank you, Swati. And I think we are doing this BLK telepits for last 2 years, and consistently every Thursday, every month on Thursday, we are doing this. And as part of our imaging part, so last time Dr. Prashant has done X-rays on abdomen. And today I'm doing on neonatal X-rays. So neonatal X-ray would include in neonates, I mean, when we are doing X-rays, so mainly we are doing for the lungs. The second most common organ which we would like to see is the GI tract, and occasionally heart, and many a times for lines and tubes. So these four things are very important in day-to-day practice, whether you are neonatologists and pediatricians, those who are working in the NICU, they must be doing X-ray for almost all the neonates, those who are admitted in the NICU. So even though the uses of ultrasounds, still we rely more on bedside X-ray. So that's why we feel that it's very important for day-to-day practices. As far as approach is concerned, I mean, everyone has a different approach, but generally we start from the, intrathoracic to extrathoracic part, and you look either from extrathoracic to intrathoracic part. And we would mainly discuss about the medical condition rather than too much of surgical conditions apart from the GI part. The surgical could be a GIT or sometimes the cardiac and pulmonary. I think Dr. Prashant has discussed something about the abdominal X-rays of neonates, but possibly there could be some repetition. So we'll continue with the basics of abdominal X-rays. When you start doing X-ray, so there are certain things you need to be more aware of that, because we know that radiation is very important, and you know that even a one CT scan would lead to around equivalent to around almost 400 to 500 X-ray radiations. So generally, while doing X-ray in neonates, try to cover the genitals to prevent X-ray related damage to the either ovary or the testis. So that is very important. And most of the time, the identity of the patient is very important. So before commenting on the X-ray, you should know the identity of the patients and the clinical conditions of the patients. And almost all of the time, we do X-ray AP view because all the patients are in supine positions. And rarely we do a PA view, rarely we do a lateral view. So there are certain disadvantages of doing AP view, that in AP view, the heart would appear slightly larger as compared to PA view. So that's why we don't comment on the heart size if you're doing an AP view. But if you want to comment on the heart size, you have to calculate the size of the heart. And mostly if it is more than the 0.6 or more than 60% of the overall thoracic ratio, then it should be considered as a cardiomegaly. In AP view, the scapula would cover some part of the lung, and this is our day-to-day practices. So we are more, well versed with the AP view of the neonatal X-rays. Anterior rib, that is the red part, which would be more visible in the AP view compared to the posterior rib. So while calculating the FRCs or the inflation of the lung, we generally count the anterior rib as compared to the posterior ribs. So overall, AP view is most important view, but many a times we also do certain views like a decubitus and cross table. So decubitus is like that. You have to keep the baby in the either one of the lateral position, either left lateral or the right lateral. And the X-ray plate would be in front of the chest wall like a PA view. So generally you can consider doing this view for infant if you're considering a small effusion or small pneumothorax. But doing a decubitus view can destabilize your patient. So try not to do unless until it is required, because nowadays to detect a small air or small effusions, you can do a bedside ultrasounds. Because if your baby is sick, intubated, while changing the positions can lead to extubations. However, this cross-table view is not uncommon in neonatal practices. So baby would be the same like a supine position. You keep the plate either of the side of the abdomen. Mainly, you do this cross-table X-ray to look for abdominal pathology like a pneumoperitoneum, because doing erect X-ray, standing X-ray would be very, very difficult, and we generally don't do erect and erect X-ray and the standing X-ray in the neonate. Apart from cross table, in the cross table view, you can also see the line positions. Like if you're putting a umbilical artery line, the umbilical artery line would be parallel to the vertebra, and the umbilical venous line would be on the near the anterior umbilical wall. So minimal pneumothorax line positions can be detected on the cross table view. So apart from AP view, I would say that cross table view is not an uncommon view. So, while commenting on the X-rays, some would follow one or few mnemonics. So, generally, these mnemonics are very commonly used, like the RIP. So, in this AP X-ray, R stands for rotations, stands for inspiratory film, or P stands for penetrations. So, if the X-ray is rotated, if you're doing a neonatal X-ray, and you it's very common to get a rotated X-ray. So try not to comment if the X-ray is rotated. Uh, so to confirm the rotations, you generally, the rotations of the lower half of the chest is much more common the upper half of the chest. So to comment that whether the X-ray is rotated or not, so you draw a center line in the spine and calculate the distance either from the inner thoracic wall or left or right side. And if the distance is same, then you call it a, central X-ray. Or sometimes you, draw a line in the vertebra and look for the clavicle if it is centrally placed or not. Inspiratory film, those who are radiologists, they allow the patients to inhale, but in neonates, it's very difficult. So to look for whether the film is inspiratory or expiratory, you look for the lung inflations and you calculate the functional residual capacity or the number of the anterior rib. So generally, well-inflated lung means 6 anterior rib. So this is this one is the red dot is suggestive of the anterior ribs. And calculate, if you can calculate 6 anterior rib, that means lung is well inflated. If you're calculating the posterior rib, that is the yellow part, this yellow part, that should be in the number of 8. The third part is penetration. So whether it's a overexposed or underexposed. So look at the retrocardiac vertebral body. It should be easily visible. If it is not visible at all, that means it is underexposed. Like in this right X-ray, it's very difficult to visualize the vertebra. So possibly it is a underexposed. Whereas in the left side, the lung is more lucent. Even the heart is looking more lucent, and the vertebra is looking like an osteopenic condition. So this is slightly overexposed. So nowadays, because of the digital X-ray, you can change the exposure while commenting on whether it's a overexposed or underexposed. So before commenting on the X-ray, look at the rotations, look at the functional residual capacity, that is the total number of anterior rib, and look at the retrocardiac vertebral bodies. Why we comment on anterior rib compared to posterior rib? Look at this left lateral X-ray. So suppose if the radiation is going from anterior to posterior, and this is the anterior rib. So if the radiation is going from here to the posterior side, suppose the anterior rib would be the 6 and the posterior rib would be this suppose a 8th number. But however, if someone is putting radiations like in an oblique way, the anterior rib would be number of anterior rib would be constant, but the posterior rib would be variable. That is why for commenting on the functional residual capacity in neonate, we generally count the anterior ribs. However, just you cannot comment on the functional residual capacity on the basis of, just number of counting of the anterior rib. You should know the clinical condition also, like this baby is a term appropriate for gestational age, having TTNB, was on maintaining saturation on high flow oxygen at 25% of oxygen. If you look at the, calculation of anterior rib, so it is just 3. So it means that the FRC is less, lung is deflated. However, this was the condition probably in the expiratory condition. So to comment on the FRC, you should also look at the clinical condition of the baby, just not on the X-ray. So that is why in neonate always correlate with the clinical conditions while commenting anything on X-ray. Obviously, just to show that this patient was on tracheostomy tube, but because there is a large neck mass, it was always rotated. And some of one of the resident told that it's at part pneumothorax because the one of the lung is looking more lucent. However, it was not there because the baby was totally rotated. And so before commenting on that, you should look for whether the X-rays, done in a rotated positions or not. So after looking this, commenting from intrathoracic to extrathoracic or extrathoracic to intrathoracic depends on you. So I generally start commenting depending on the this mnemonic. A, B, C, D. A stand for airway. That means we are going from inside the thorax to outside of the thorax. B stand for bone. We look at the bones of the humerus, or sometimes if you look at generally 3 bones we look in neonates. That is, one is humerus, that vertebral bodies for retrocardiac vertebral bodies, or to look for osteopenia or prematurity. C, cardiac. Look at the both cardiac silhouette on the left and right sides. D, diaphragm. Look at the dome of the diaphragm. And then E stand for extracardiac, that is lungs, pleura, or below the cardiac, below the diaphragm. You look for the GI tract also. So look at this X-ray, and this X-ray was of a preterm neonate. Was initially intubated, remained intubated for 1 week, and then extubated, was maintaining saturations on heated, humidified, high flow oxygens. So if you look at the trachea is central. So X-ray is also central position. There is no rotation, so we can comment. So position of the trachea is very important. In neonate, the trachea should be either central or slightly rotated towards the one side, right side. And many conditions, the trachea would be pulled or pushed depending on the clinical conditions, like depending on the if there is a mediastinal lesion like pneumothorax, pleural effusion, the trachea would be deviated towards opposite sides. If there is some lesion like some fibrotic lesions or some, collapse of the lung, trachea would be shifted towards the same side of the lesions. Many times lesions can compress the airway, mainly the trachea, if the arch of left side of aortic arch, and the tracheal positions would be shifted on that side. Also look at if the baby is intubated, you look at the ET2 position. So we generally target ET2 position just above the carina. So that's why airway is important. So apart from airway, look at the caliber of airway. If your baby is intubated for longer periods, even a small baby, trachea, the airway gets dilated. And if you start non-invasive ventilation, they sometimes they don't maintain saturations because there is a lot of dead space is created because of the in long intubations. Because in neonates, in preterm neonates, you start intubating with a small ET tube, and gradually you start changing the tube to the larger size. That will create a larger dead space. So in that case, you should put a appropriate size nasal cannula, and sometimes you need a more pressures to maintain this airway intact. And that's why, so to avoid this I mean, if the baby is having large dead space, you have to give a lot of pressures to maintain the saturations. So this is one of our baby who had some I mean lesions in the chest, I mean the cardiac lesions, and in X-ray you can see the airway is slightly deviated on the left side. Because when we did a CT scan, we found that there was some lesions here that was compressing the airway. So generally, the airway would be shifted towards central side or towards the right side. So any deviations towards left side, if the lungs are clear, if there is no mediastinum lesions, and if the baby is not maintaining saturations, look at the other lesions to rule out any compression of the trachea. As I told that the trachea, I mean the airway would be shifted on the same side if there would be collapse. So like in this X-ray, this X-ray was slightly rotated, but there was a collapse on the right side. You can see the overcrowding of the rib, and the trachea was shifted on the same side of the lesions. And look at the other side of the lung. Other side is slightly overinflated, look like a overinflated lung on the left side. So this was again a slightly rotated film, but you can see this airway is slightly dilated. I mean, the trachea is slightly dilated here, and because of this dead space creations, baby was requiring high PIP and high positive and expiratory pressures to maintain the saturation. So, I mean, airway is important part when you are commenting on X-ray. So now the bone. So I told you when we are commenting on bone, 3 bones are important. One is humerus, second is vertebral body, and third is if the femur is visible or not. That's also important. So looking at the humerus, you can say that I mean what is the maturity? More is the immature baby, there would be more osteopenic area of the head of the humerus. But more commonly, we comment on the vertebra. So compare this first X-ray versus the second X-ray. You look at it is very difficult to visualize the vertebral body. This baby was a 26-week baby and was on ventilator for longer period and required nutritions. But because of the non-availability of phosphorus, and patient had losses of phosphorus through urinary route, so this leads to hypophosphatemic rickets. So this hypophosphatemic rickets happens very commonly in preterm neonates because of the low calcium and low phosphorus because of the immaturity of the kidney. So nowadays phosphorus is available. So to look that whether it's osteopenic or not, you just look at the vertebra. It's very difficult to visualize vertebra compared to this X-ray. So this is a case of osteopenia of prematurity, which is very common in preterm. To prevent this, you I mean provide calcium phosphorus along with vitamin D to prevent these conditions. And initial days when the baby is not on any oral feeds, sometimes if the phosphorus is available, you can give a IV phosphorus to the patients. I'm just arranging this X-ray. Just look at the humerus at different gestation at 27, 29, 33, and this last is term infants. And look at the humerus. Humerus is, I mean, not looking very dense and it's immature. So just looking at this humerus head, you can comment that whether it's a preterm or a term baby. Because it's very difficult to get, knee X-ray in all the infants, because in neonates, you do X-ray of chest along with abdomen most of the time. So you will get the humerus X-ray, along with that your vertebral body X-ray. C stand for cardiac silhouette. So they look at the cardiac silhouette, and when you are looking at the cardiac silhouette, you comment on 2 things: whether the cardiac enlargement is there. To calculate the cardiac size, you draw a line over the right cardiac silhouette and you another line on left cardiac silhouette and draw a line, and then you compare with total thoracic length. You calculate the thoracic length from inner wall of the one side of the thoracic wall and another half of the thoracic wall, and if it is more than 0.6, then you can say it's a cardiac enlargement. Otherwise, generally we don't comment on supine or AP view of X-ray for at least size of the heart is if the size of the heart of the concern. Second part of cardiac silhouette is important. If you are commenting on the lung, also look for whether the cardiac silhouette is clear. You should clearly demarcate the diaphragm, right cardiac margin and the pleural margin. If this margin is lost, I mean, if the right cardiac slot margin is lost, mainly it is abetted by the right middle lobe. So if any loss of this margin would suggest that the lesion would be on the right middle lobe, whereas in the left cardiac slot is mainly abetted by the lingular lobe of the the left upper lobe. So if the left cardiac shadow is, not clear, then you can say that it's because of the lingular lobe lesions. So while commenting on cardiac shape and the cardiac slot is important. So just commenting on this X-ray on the left side, you can see that the right cardiac slot is, margin is lost. That means possibly the lesion is mainly on the right middle lobe, whereas on the left side you can see the left cardiac margin, left cardiac slot is not clearly visible. So possibly the lesion is of the lingular lobe of the left upper side. So generally we don't do lateral X-ray of neonates, so it's very difficult to comment on the lower lobe. However, most of the time, if you want to comment on the lower lobe, you look at the diaphragm. So diaphragm should be, easily demarcated from the right cardiac margin and the left on the other side by the pleural margin. If this margin is lost, if it's you are not able to delineate the right diaphragm or the left diaphragm from the lungs and the right cardiac margin, possibly this could be a lesion of, along with medial lobe, if the lower lobe lesion could be there. Like in this X-ray, you can see it's very difficult to demarcate between the diaphragm, the right heart margin, the left heart margin. So this patient has, prolonged ventilations leading to the, ventilator-associated pneumonia. So clinically, you can comment on that probably on the right side, there is some overinflation of the one of the posterior recess of the lung. So possibly the lesion could be of right middle lobe and right lower lobe. In the left side also it is because the left cardiac margin is not visible, and as well as the diaphragm is not visible. So possibly the lesion is of probably, the lingular lobe and the upper lobe and the left lower lobe also. So because we can't do the lateral X-ray in newborn, so generally you can comment on the lobar lesions depending on the cardiac slot and the diaphragmatic positions. While looking at below the diaphragm, so below the diaphragm, just one thing I want to just say that when you are looking at the diaphragm also, the dome of diaphragm is also important. The right dome of diaphragm is just falling mid-clavicular line on the right side, whereas on the left side, the left dome of diaphragm is slightly lateral to the mid-clavicular line. Right dome of diaphragm is slightly up compared to the left lobe of the diaphragm. So any flattening of the diaphragm, whether on the right side or left side, would suggest that probably the lung is overinflated. Like if you are ventilating the patient, sometimes overinflated lung, high FRC can be there. So in that case, you can, decrease your ventilatory settings depending on the, the overinflated FRC counting and the position of the diaphragm. Sometimes those who are doing high frequency ventilation, it's very frequent to get, flattening of the diaphragm. So looking at the diaphragm, you can comment on various lesions of the lung. While looking at the below the diaphragm, so below the diaphragm on the right side is the lesion. The two organs are there. One on the right side, liver, and the left side, the spleen. So the liver, the density of liver would be slightly lesser as compared to the rib or as compared to the heart. Any lucency near this liver area would be critical situations, because you should not see any lucent lesions near below the diaphragm that's over the liver. On the left side, because almost all the X-ray in the supine and the AP view, so you can see this one of the line of air fluid level in the stomach, because baby is in the supine positions. So any lucent lesion near diaphragm, below the diaphragm, or over the liver would be a important clue towards air leak in the abdomen. So liver size, to calculate the liver size, it's very difficult to calculate this liver size. Just an eyeballing can sometimes help you whether the liver is in large or small. So there are two places below diaphragm you can get an air fluid level. One, I told you, that stomach, and second near the rectum. Any place where you are getting air fluid level away from rectum and stomach is generally pathological. While commenting on the bowel, so it's very difficult to comment on whether it's a small bowel lesions or large bowel lesion in neonates. It's very difficult to comment. However, when you draw a straight line from the vertebra and make a 4-quadrant, the bowel lobes should be visible like a honeycomb or pebble-like. If any linear or vertical dilatation, lengthwise dilatations, would be considered significant in presence of some clinical settings. However, sometimes the old data suggests that whether the dilatation, linear dilatation, is abnormal compared with the lumbar vertebra. You just calculate the size of the two lumbar vertebra lengthwise, and if it is any gut dilated lengthwise more than this, is considered as a abnormal dilatations, or any size more than one of the thumb of any doctor, I mean adult doctor, which is considered to be a, abnormal dilatation of the GI tract. So this is very important while commenting below the diaphragm. So and look at the gas pattern while commenting on the GI tract. So you will get a gas in the duodenum by 1 hour of life in a newborn, and in proximal small bowel by 3 hours, and distal small bowel 12 hours, and by rectum 24 hours. So why I'm saying this? Because if you are commenting on obstructive lesion of the GI tract, it is not recommended to do X-ray as soon as possible immediately after birth. Try to delay the X-ray. If you want to do X-ray as soon as possible, so push some air, because air, I mean, if you are commenting on the distal small bowel by 1 hour of life, because you don't expect gas to reach there. So if you want to do, X-ray, so push some air, around 10 to 15 ml of fresh air, and then you can do an X-ray. Second thing, this type of gas is a normal gas. So any absence of gas after few hours of life, it's considered to be abnormal. Either if it's a complete white-out abdomen, is a severe abdominal issues. So that severe abdominal issue would be a severe NEC, sometimes subacute obstructions, and sometimes, a large, obstructions leading to the, volvulus-like condition leading to the bowel edema. They would present like a gasless abdomen. So this type of gas is very important. If you're finding gasless abdomen, that's a very, very bad conditions. Or any gases outside the lumen would be also very important to know specifically in a preterm baby, because this would be one of the signs of the the necrotizing enterocolitis. So paucity of gas is important to know whether it's a high or it's a low obstruction. So any fluid level, air fluid level of 3 or more would be considered or suggestive of a high intestinal obstruction. So if it is multiple in number, so it could be the lesion of below the jejunum. So these are the common neonatal intestinal obstructions. So gastric outlet obstructions is most not uncommon beyond 4 weeks of life, like hypertrophic pyloric stenosis. Duodenal obstructions like duodenal atresia, malnutrition, so anal pancreas can lead to a double bubble like appearances. Below duodenum, jejunum, and ileum can lead to more than 2 bubbles, and the chronic obstruction would lead to a multiple air fluid levels. So as I told initially that while commenting on neonatal X-ray, so always comment on the basis of clinical settings. So in GI, if it is a upper half of obstructions, they would present a more like a vomiting first, and then upper half of abdominal distensions. So whereas the lower half, that is a distal GI obstruction, they would present more like a gradual increase in the abdominal distensions and then leading to the vomiting. So while commenting on the abdominal issues, you look at the antenatal issues. So many time obstructions would lead to antenatal, a lot of polyhydramnios. So look at the amniotic fluid also before, comment. Look at the antenatal history is also important while commenting on the neonatal intestinal obstructions. So this X-ray was done 1 hour of life. Neonate presented with bilious vomiting. You can see the small two gases, one at the stomach level and one at this level. So I mean, after a few hours, when we I mean, even at 1 hour fly, we push some air of around 20 ml of air to rule out whether it's a upper half of obstructions or not. So it was a case of double bubble appearance. So as we discussed that, this is a case of I mean, stomach dilatation, and this is the second, this is the duodenal dilatations. So possibly it's a case of duodenal atresia. So another neonates presented with bilious vomiting with large gastric aspirate. It was green, yellow aspirate. And so when we did an X-ray, so you find three bowel gases. One is the stomach bowel, the second is a duodenum, and third is the jejunum. So this was a case of jejunal atresia. Once the air levels, I mean the number of air bubble levels increase, and you can see in the another X-ray there are a lot of air fluid levels. So this could be a lesion below the jejunum, possibly due to the either the large colonic atresias or sometimes the I mean the ileal atresias. So as I told you that if the abdomen is showing a gasless, so gasless abdomen is a very bad abdomen in presence of some clinical settings. These neonates would be a very sick neonate, severe tenderness of the abdomen, large aspirates, sometimes no aspirates because of the perforations. And I mean, this suggesting of a severe bowel edema. I mean, sometimes in cases of severe NEC also, you can find this. Sometimes in cases of volvulus, sometimes malnutritions can lead to these type of, I mean, gasless abdomen. So out of all these, the gasless abdomen, I mean, would be considered as a very bad prognosis because the chances of having gangrene is very high. So, like one of the case of this, I mean, malnotations presented with this. So we know that to rule out the malnotations, you do a I mean, ultrasounds to look at the, I mean, the Doppler view or the supramesenteric artery. You will get a supramesenteric artery, supramesenteric vessels, reversals, but as well as you can, if the Dopplers is not available, you can do the upper GI studies and look at the abdominal conditions. Look at this stomach is hugely dilated, duodenum is dilated, and this DJ junctions on the right side. You will get it normally. You will get the DJ junctions on the left side of the vertebra, whereas in these conditions you are getting DJ junctions on the right side of the spine. So this was a conditions of a malnutrition, and this baby was very sick and was operated on the day one and had a stomy course. Another case, this 5-day-old baby had, I mean, some issues with feeding and progressive abdominal distension was there. And when we did X-ray was suggestive of this, I mean, hugely dilated bowel loops. But it's very difficult to comment whether it's, I mean, small bowel conditions or the large bowel obstructions. So because I told you it's in neonate, it's very difficult. So because the presentations was like that, this baby had abdominal distension and followed by vomiting, whereas in proximal distensions, you will find a vomiting first, followed by abdominal distensions. So in these conditions, it was very difficult to comment. So we thought that the patient presented with progressive distension, so we plan to do a barium studies. So nowadays we don't do barium studies. In place of barium, you are doing gastrographin studies because the barium gets stuck with your old meconiums, and it's very difficult to, I mean, excrete the meconium from the bowel. So that's why we use a water soluble gastrographin. They get easily absorbed in the body, and they can be excreted. So that's why we avoid barium, like because it can lead to some problem in the neonate. So nowadays we use a gastrographin. So you can see this is the collapsed bowel loop. This was a case of atresia, large bowel obstructions. So in this case, this was diagnosed after gastrographin studies only. So I told you that liver size below the diaphragm, you're looking that liver size is also important. You look at this three liver. This was the normal liver, and this liver size was very small. Gradually, this is a very small liver size, and this was a case of neonate who was presented with DIC and bleeding, had abnormal high PTA-PTT, and this baby had some liver necrosis and liver injury. So liver size is also important while commenting on the X-ray abdomen. look at this X-ray. I mean, this baby was 26-weeker, who required intubations and then on nasal ventilations. And on day 4, day 5, baby had deteriorations, mild abdominal distance. And so this X-ray was done on the supine view, and it was very difficult to comment. But if you look closely, you can see the lucency over the below the diaphragm on the right side, just over the liver. I told you while looking at the X-ray, you just compare the density of the liver to your heart. If it is less, then it is a lucent size towards on the lucency side. So if to confirm this, whether it's air or not, because it's very difficult to, I mean, a sick neonate to doing a erect X-ray. So we did a, I mean, cross table X-ray or sometimes even a decubitus. Decubitus is very difficult to do, but in this case we did a decubitus X-ray. But even if you are doing a, I mean, cross table X-ray, you will find the air in front of anterior abdomen, and it was a case of gastric perforation because of a lot of air in the abdomen. And this baby developed, I mean, spontaneous intestinal perforations because of the prematurity and because of the possibly because of the on non-invasive ventilation through the I mean, we are using various type of optiflow or nasal cannula through the nose in a ELBW infant. So while giving non-invasive ventilations, to make it more successful, always look at abdomen. If your abdomen is good, then and then you can consider continuing non-invasive ventilations through nostril. Otherwise, it can lead to problem. And sometimes, while putting the orogastric tube, you look at the orogastric tube positions. It should follow the greater curvature of the stomach. In a small preterm baby, you're putting OG tube in a very, I mean, very fast manner. Sometimes even a small OG tube can lead to gastric perforations in the neonate. So always try to look at the OG tube positions, whether it's lying on the greater curvature or not. And if it is too much inside, sometimes it can lead to gastric perforations, because many a time this baby would must be getting some paracetamol for the, I mean, for duct closure. Sometimes they get, I mean, they are on steroids for chronic lung disease, or sometimes for prevention of chronic lung disease like hydrocortisone. So these all things, prematurity, non-invasive ventilations, abnormal positions of orogastric tube, or if your baby is on steroids, they can lead to early, I mean, stomach perforations. So that's why it's very important to look closely over the X-ray abdomen. So these are the various X-rays of the neonate. So the first X-ray, this is showing a complete gasless, very bad. This was a case of severe NEC. This baby could not survive because of the bad gangrene of the abdomen. If you look closely on this second X-ray, the dilatation was, I mean, a whole abdomen is dilated. Liver is, I mean, lucent comparing to the heart, and there is a thin line below the diaphragm. So it was a case of pneumoperitoneum. The third X-ray is suggestive of, I mean, bowel is dilated. Patient was clinically, I mean, sick. And if you look closely, there is a lot of air in the portal venous cases. This was case of necrotizing enterocolitis. So that means these are the extraluminal gases. The other way to detect, like in this patients, we did a cross table, we find a lot of air below the anterior abdominal wall. Again, it was a case of pneumoperitoneum, which was missed on supine X-rays. And accidentally, if someone is putting I mean, UV line and pushing air in place of saline flush, you can find air also in the, I mean, portal tract. I mean, just like cases of necrotizing enterocolitis. So, but this baby was, I mean, clinically normal. There was no abdominal issue. So while commenting on the portal venous gases, so you just look at the clinical condition of the patient. Sometimes accidental pushing of the air can lead to air in the portal. I have added these two X-rays. If you look at this X-ray, it looks like some intraluminal air, I mean, in just below the liver, and possibly looks like NEC. But this baby was a 25-weeker on full peat and but not passing stool daily. It looks like a gasless, I mean, very less gas compared to the normal neonatal X-ray. But again, I told you that look at the clinical conditions. Baby wasn't full feed, abdomen was soft, there was no aspirates, baby was passing stool, I mean, infrequently. That's why we sometimes do use glycerin suppository or glycerin rectal wash. So it's a sort of pneumatosis, but it's not a pneumatosis. So someone has given this name out of pupatosis. That means a fecal overload. Again, as I told that another conditions, 25 acre on steroids. I mean, it's like a football-like abdomen. I mean, lot of air. It was because of the gastric volume. So just looking at the X-ray abdomen, you can, I mean, comment on various clinical conditions related to the surgical or sometimes medically related illness of the neonates. So this has, I already told you that, yes, below the diaphragm, this portal venous cases because of the iatrogenic pushing of the air. And again, I mean, look at the both diaphragm. So right side diaphragm is intact, but left side diaphragm is not visible. And there is a lot of cystic lesion in the left side of the heart. So there could be some lesions on the heart because the diaphragm is not visible. Possibly this was a case of, I mean, congenital diaphragmatic hernia, fifth slide, shifting of the heart on the towards the right side. So we have already discussed about the A, B, C, D, and now the E. The E is the, I mean, look at the, I mean, the extra, extra cardiac part, look at the lung margin. While comparing the lung margin, your both side of the lungs should be equally visible. In neonates, most of the medical conditions are bilaterally symmetrical. I mean, asymmetrical lesion would be either a acquired lesion like a ventilator-associated pneumonia, or it could be a surgical lesion. So homogeneity of the lungs should be bilaterally symmetrical. If it is asymmetrical, there could be some problem. Air bronchogram should be, I mean, equally visible on both sides of the lung. Generally, we don't see vascular margins in the lungs of the neonate. Any vascular margin visible over the apex or lateral 1/3 of the lungs is an abnormal. This could be an probably a overcirculation lesions like a PDA or some plethoric lesions of the lung. So as I told that, look at the, compare the both side of the heart. It's a slightly rotated film. The right side is looking at a more lucent compared to the left side of the lung, and you can see the pocket. So it was not, it was some, I mean, air pocket, but this air pocket was not outside the pleura. So this way was on nasal ventilation. So just changing your ventilatory parameter would decrease the, I mean, lucency, and patient would improve with time. Like in this cases, you compare the right side of the lungs compared to the left side. So left side is, I mean, looking like a more lucent. So because of probably overexpanded lung, and we was on non-invasive ventilation. So just decrease your ventilatory pressure, you will find an improvement in the clinical settings. And if you want to repeat the X-ray, you will also find the same improvement in the clinical settings also. This is X-ray of a neonate. You can see there is an obviously a asymmetrical lesions over the lungs compared to left as compared to heart. Heart is slightly shifted towards the right side, and you are not able to delineate the right heart of the lung. I mean, the right cardiac slot is not visible. This is a very premature baby, was intubated, given surfactant, and probably one of the alveoli gets ruptured and the air comes out. And you can see there's a linear cystic lesions on the left side of the, I mean, the thorax, and looking like a honeycomb appearance. So this is not uncommon in an extreme preterm and a smaller baby. We call it a pulmonary interstitial emphysema. The important would be that patient were, I mean, destabilized, required high oxygen requirement. You did an X-ray, you find this X-ray lesion. So on this X-ray, what you have to do, you have to change the position, because the air is not outside of the pleura. So you don't need to put a, I mean, ICD to remove the air. You just have to change the positions of the patients. So to give rest to the left side of the lung. So keep the baby positions on the left lateral and try to decrease the pressures, mainly the PIP, because this sort of small preterm baby, if you are using a very high PIP, and they will increase in the pressure of the neck and ultimately transferring this pressure to the brain, they can lead to some brain damage or intraventricular hemorrhage also. So just see the second X-ray just after 24 hours of keeping the baby on the left lateral side, and maintaining saturation just on the, we're tolerating, PCO2 on the borderline like 45 to 55, and maintaining saturation between 90 to 95, and just decreasing the PIP. These patients improve within 24 hours. So this is a linear honeycomb-like, linear cystic honeycomb-like lesion and a premature baby. This is not uncommon, but nowadays, because of the uses of early surfactant, early uses of delivery room CPAP, transporting the patient on the CPAP to the NICU, and using less and less invasive ventilations, you don't find such type of PI. But if you find such type of lesion, you have to treat it conservatively. The other part of air-related lesions, like looking at the right thorax versus left thorax, you can see there is a uh, air lucency near the surrounding the heart. I don't know whether you are, can visualize or not. There is a more lucent right side of the heart near the right heart margin compared to the left heart margin, and there is a uplifting of the thymus. So if there is a such type of air near the mediastinum and uplifting of the thymus, this could be because of the pneumomediastinum. But many a time you will find the air, like if you compare the right thorax compared to the left thorax, there will be a broad around 0.5 to 1 centimeter of air lucent lesion near the left cardiac ciliate compared to the right cardiac ciliate. So this air is the air near the visceral pleura. The air is not outside the pleura. We call it a medial pneumothorax. It's a not a air not outside the pneumothorax. It's a very, very common lesion in neonates. So once you get this type of lesion, you just have to decrease your ventilatory parameter and keep the baby rest on the left lateral side. If the lesion on the left side, they will resolve by itself. If you don't take any measures, this can lead to progressive air leak and leading to the sometimes pneumomediastinum versus pneumopericardium, sometimes pneumothorax and pneumoperitoneum also. To differentiate between medial pneumothorax versus pneumomediastinum, one point is that this in medial pneumothorax, it will never uplift the thymic shadow, whereas pneumomediastinum will always, you will get a uplifting of thymus. So just to differentiate between pneumomediastinum and medial pneumothorax, the treatment would remain the same: decrease the pressure, change your ventilator settings, but diagnosis would be different. So in this X-ray, so if one of our patients, you can see the large margins. It's very difficult to delineate the right heart margin, and there is a large margin of, lucent right side of the thorax, and this was a case of, medial pneumothorax. Sometimes they can present in a, this medial pneumothorax along with pneumomediastinum will be present. Like in this case, you can see there is a lining over the the right side, and this progresses towards to pneumomediastinum. Now the uplifting of the the thymus. So it's all started with medial pneumothorax, and because we didn't took actions to decrease the pressures of ventilatory pressures, so it progresses to the pneumomediastinum. And if you don't take actions, then air will come out of the pleura, and it will lead to pneumothorax. So here, in pneumothorax, the vascularity will be not seen on that side of the, the thorax if there is a air outside the pleura. So these are the different type of air leaks. Like you started with PIE, then the medial pneumothorax, then pneumomediastinum, and this pneumothorax. And sometimes these bad X-rays, those patients who are on a prolonged ventilations, you will find one part of lung is, one part of lung is overinflated, like this hugely dilated one part of the lung, and they shifted towards the lung is overinflated in 5 meters and shifted towards on the left side. So these all type of related to air related lesion, air in front of the heart. So these are the bad lesions. They sometimes, even if it is not outside the pleura, you need to put a drain to drain the air wherever it is, to to improve the patient. So even if it is not outside the pleura, sometimes you put ICD on the right side because of the, and sometimes you also put both side ICD to decrease the ventilatory settings. This was a case of, late preterm on high ventilatory settings of hypoxic respiratory failure, having PPHN on high ventilatory settings of HFO. You will see, the right side is prominent, lucent, and this air is going inferior border of the heart. So this baby had acute deterioration. So unfortunately, this X-ray was done almost 6-7 years back. At that time, we, didn't have the facility of doing echo because patient deteriorated. So what we did, that we feel that obviously it started with some air leak in the pneumomediastinum and then progresses to the pneumopericardium. So we put ICD because we thought air was on the right side. So once we put an ICD on the right side, so air decreased and gradually baby improved in form of related to the pneumopericardium. And after 24 hours, you can see the baby has improved. All the air was gone, and we were able to extubate the patients after 4 days of intubations. To differentiate it between pneumomediastinum versus pneumopericardium. If someone is doing lateral X-ray, you can see the air would cross the central tendon of the diaphragm. If the air is not crossing the central tendon of diaphragm, then it is not pneumopericardium. Possibly it is a pneumomediastinum. So day one X-ray chest 36-weeker, 2,700 grams, and was having respiratory distress with a Silverman-Anderson score of 6. You can see the asymmetrical chest wall, hyperlucent on the right side, middle lobe. There was a mediastinum shift. So it was it was very difficult to delineate the right side of diaphragm. So it was actually the air was in the lung, but not outside the lung. So probably with some changes in the ventral setting, baby is improved. So apart from air leak syndrome, so the second common is hyaline membrane disease. We call it a respiratory distress syndrome. This is not uncommon. So the severity of the HMD would be, you will get a, reticulogranular pattern, more of granularity in a milder disease, and more of air bronchogram in the moderate disease. And in severe disease, you will get a whiteout lesion. But I'm just telling that nowadays we don't see this type of whiteout lesion where it's very difficult to delineate between the lung, heart, and the diaphragm. It's a complete whiteout. The reason is that because we start treatment early, right in the delivery room, we start CPAP right in the delivery room. So you won't get this type of severe respiratory distress nowadays because of the early use of CPAP. However, many times you will find a bad X-ray, but baby is on a minimal setting of CPAP. So just don't comment on severity of RDS just on looking at the X-ray. Always comment depending on the clinical scenario, calculate your Silverman-Anderson score and look at the walk-up breathing, look at their FiO2 requirement, and then can say whether it's a mild, moderate, or severe disease. So nowadays we categorize on the basis of FiO2 requirement and on the basis of score rather than looking at the X-ray. But obviously you will find reticulogranular pattern or a lot of atelectasis in, hyaline membrane disease. This hyaline membrane is formed because of the leakage from leaking of the proteinous material from the alveoli because of the inflammations. So, but nowadays it is not very common. Second thing, I told that all the medical illnesses like the RDS, congenital pneumonia, they are generally bilaterally symmetrical. They are not asymmetrical. Any asymmetrical lesion would be either iatrogenic, community acquired, or sometimes related to ventilations. Like compared to this left X-ray, this is a right-sided complete whiteout, and it's a one-sided lesion, whereas compared to the left side is a bilaterally symmetrical. So both are pneumonia. But this pneumonia is a hospital acquired. Baby was intubated, remained intubated, and developed ventilator associated pneumonia. Whereas congenital pneumonia is generally early onset sepsis leading to, X-ray would be suggestive of hyaline membrane disease or like a RDS. So it's bilaterally symmetrical compared to asymmetrical lesion. Whether it's a consolidations or the collapse, you compare the lung lesions, that's the white part, with the liver. If this lesion is similar to the liver, that means it's mostly a collapse. If the lesion is consolidations, you will also find air bronchogram. So in this X-ray, there is no air bronchogram. I mean, X-ray is central. There is no mediastinal shift, but still, this was a case of, I mean, collapse. We confirm it with the ultrasound also. So it was a case of collapse, not a consolidations because of the ventilator-associated pneumonia. So sometimes effusion can also be there. So to rule out lung lesion nowadays, the ultrasound is the gold standard. Nowadays, we do ultrasound for all the patients having whether it's a hyaline membrane disease or it's a pneumothorax or it's consolidation pneumonia. So because X-ray is a one-time process, whereas ultrasound we can do continuously many times, and it has no radiation. So now it is gaining in practice. However, you have to learn ultrasound to look to know about the lung lesions. In the lung hypoplasia, again, I told you that the FRC is low, the heart, the lungs are not well developed, so thoracic cavity is small. So it's like a bell-shaped heart, bell-shaped chest wall. So if such condition is there, so right in the delivery room, your management would be variable, because you don't want to give a lot of PP, even though the heart is, it's a whiteout lesion, but because if you are giving a lot of positive and expiratory pressures, this will lead to early air leak and pneumothorax, and it would be very difficult to save the baby. So antenatal history is very important, and looking on the antenatal history, if you find severe oligohydramnios leading to lung hypoplasia, your treatment should be optimum just on that basis. The chronic lung disease and bronchopulmonary dysplasia is not uncommon. So there are, old BPDs and new BPDs. So I'm not going into detail, just to understand that the old BPDs were generally a larger baby where you intubated the baby. Your vent settings were very high. They required ventilation for a longer period. They also developed pneumonia, and you will get different all spectrum of lesion. Few of the, part of the lungs are atelectic. Few of the part of the lung are overinflated, few parts are fibrotic. You will have all sort of lesion. Whereas in the new BPD, it's all because of the immature lungs. So lungs are still not developed. So alveoli are still not in an adequate number. So you will find this type of X-ray of HMD. So in this scenario, so you should know the clinical conditions. Obviously, if it's a case of chronic lung disease, baby would be a month old, still on high flow, on some oxygens, and you will get this X-ray. If you're doing some X-ray for some other reasons, you will look at the vertebra and the other bones, they are osteopenic. So old means slightly mature baby with some acquired lesion related to ventilations, infections. New means it's because of more of the immaturity. TTNB, very, very common, specifically in a late preterm and term infants born after cesarean sections. So generally, I told our fellow that TTNB is a conditions like a mild heart failure. You will find a slightly larger heart, lot of fluids near the lower base of the lungs, and they may be find enough fluids in the fissures, and they generally improve within 24 to 48 hours. The traditional teaching was that you should give oxygen for 24 to 48 hours, but nowadays you treat patients on the basis of Silverman-Anderson scores, and you look at the work of breathing. If the work of breathing is there, you start CPAP or high flow rather than just giving a plain oxygen. However, once the patients improves with if their urine output improve, they went to the diuresis, the lung, the lung fluid will be disappears. Meconium X aspiration pneumonia is not uncommon, but it has a spectrum of disease. They can present with a mild distress like a TTNB, they can, and severe like a PPHN. If it is pneumonitis, they will present like a congenital pneumonia, bilaterally symmetrical lesion like a pneumonitis. If the airway is getting blocked with a large meconium, they would lead to collapse. So coarse textures of the lungs can be visible, but it should be defined on the basis of clinical setting. So you will find all sort of lesions in meconium expression syndrome, and not always just large collapse of the lungs. There are one or two important points in pneumonia and meconium aspiration syndrome and TTNB. If you're doing ultrasounds, you will get effusion. In pneumonia, you will get effusion in up to 40%, because the X-ray would be same like an HMD or pneumonia, or sometimes a chemical pneumonitis of MAS. the X-ray would be same in many conditions. So you just to do, ultrasound and look for the effusion. If effusion is there, the possibility of pneumonia could be there in presence of clinical settings. And obviously, we have already discussed about the FRC conditions. Though the lung is not recruited. The atelectic lung. So HMD, the FRC would be less, whereas it compared to the MS, where the FRC would be high, overinflated lung. Thymic pseudo is not uncommon. Doctor,
Yeah, Dr. Ankur, it's 4 already. So
it's a long exercise, so we can stop after this. Okay, so it's already 4. So in 5 or 7 minutes, I will stop.
yeah, sure.
Okay, so thymic pseudo is very, very commonly seen in neonates. There are a lot of signs of thymic pseudo. Generally, if the condition of respiratory distress is severe, they would disappear. If the condition is mild, they would reappear. So they appear and disappear very quickly. And you look at the T3 vertebra. If the thymic size is more than the size of the thoracic vertebra, you call it a thymic enlargement. And there are many signs like knot signs, sail signs, and wavy thymus. These are not uncommon. So then don't get confused. Sometimes it feels that the cardiomegaly is there, but look at other signs of the thymus, because you can see through the lungs, through the thymus. It never compresses the airway. So on this basis, you can comment ductal pumps are not uncommon in term infants. They look like a aortic bump like condition like an adult, but obviously aorta is not that mature in a neonate, so they appear and they disappear very commonly. Skin folds. I'm not going to the hard details. So Dr. Swati, we can stop here because
Okay, Dr. Ankur.
for
So, thank you, Dr. Ankur, for such a detailed and informative presentation. You have very well highlighted how systematically to approach X-rays to derive maximum information from it. And now, quickly, can we have some input from our chairpersons? And I request audience to post any questions in the chat box, or you can unmute yourselves and ask the questions.
Thank you, Dr. Ankur. That was very insightful and informative lecture. So very nicely, you have emphasized the importance of positioning, proper interpretation of the X-ray, and this A to E, whatever formula you have given, that is very nice systematically how to review X-ray going from the center to the lungs, then to the cardiac, diaphragm, and beyond that. And I would like to add an F to it, that is the foreign body, also to this thing. If there are any questions from the audience. So yes, there's a question from Amir. Can you explain air bronchogram once again?
so I have to
Dr.
reshare. So I have to reshare the X-ray. So let me. I think he must be talking about the RDS related air bronchogram. So any.
Like if in any opacity, if you see lucency.
Okay,
branching,
so air bronchogram means, if you look at the condition of respiratory distress syndrome, this is a condition of surfactant deficiency. So that means many of your alveoli are not opened up. They are atelectatic. So there is no air in the alveoli. However, there is air in your terminal bronchiole. So you can see that the white dots, all the white dots it's a atelectatic lung. And then you can see the large in the terminal bronchioles. You can see the air you can see. Though this is a air bronchogram only. Whereas compared to this all, alveoli are collapsed in these conditions. And because of the severe RDS, there is a lot of, proteinaceous fluid. That's why it looks like a complete white out lung. So air bronchogram is visible in this X-rays compared to this. In this X-ray, it's very difficult to comment on the air bronchogram.
Thank you, sir, for a detailed elaborate presentation. Dr. Adi is asking, up to what age thymus can be seen in X-ray?
Thymus can be seen, up to what age? 1 to 2 year, Dr. Kanika. I mean,
It can be seen throughout, like in infancy
even
and childhood, and then gradually regresses in size. Yeah,
but in neonates, I mean, it's
can
very tricky. Sometimes it disappear on the same baby because of the severity of lung condition. If the lung is severe, they would disappear. If the condition is mild, I mean, a normal neonate, you will find thymic shadow. Whereas, like in this X-ray, it's very difficult to see any thymic shadow because this baby was having a severe RDS, so they would disappear very quickly. So up to, I mean, certain is the immunity of, I mean, 2 years. I mean, and probably thymic shadow can be visible.
2 years, then it gradually regresses.
Sir, one point to just clarify, when some babies are getting X-ray done repeatedly, other babies in the same area, they need some screening while doing X-ray?
I didn't get your point.
So when in a one cabin, let's suppose there are 5 babies.
Okay.
And one baby is sick, other parents are complaining that my babies are getting exposure for X-ray. So do any NICU have protocol for keeping them safe?
I think most of us are not using too much of radiation because of localized X-ray. So I don't think if your distance is 200 square feet, more than 200, 300 square feet from a distance between 1 or 2 patients, if it is not overcrowded, it would not cause too much of radiation-related exposure.
Yes, will not cause.
If your nursery is having too many patients,
like
Then
Rampi, that will be a violation.
then in that case.
Okay, I don't think any other queries are there.
Yeah. Dr. Prashant was there, the audience. Dr. Prashant, are you still there?
And thank you, Prashant. I mean, a few of the X-rays are from Dr. Prashant's, database. So thank you, Prashant. So
Yeah, very good collection of cases for the X-rays too.
Yeah, most of the X-rays are from our patients only. So apart from 1 or 2 X-rays, I mean, few of the thymic shadows X-ray. Otherwise,
yeah, Dr. Prashant has left. So we have come to the end of this enlightening session on neonatal X-rays. I would like to thank Dr. Ankur for such a detailed and informative presentation. I would also like to extend a sincere thanks to our chairpersons for sharing their valuable time and expertise. And thank you to the audience for joining this session. And next month, second Thursday, we would be back with another interesting session of BLK TELE. So join us for the next session. Thank you once again. Thank you, everyone.
Thank you.
Dr. Swati, Dr. Sushant, Dr. Kanika, thank you for joining.
Thank you.